Hello, everyone. This is Dr. Mikky recording a lecture on Chapter 12, which is the cholinergic drugs affecting the ANS, which is the autonomic nervous system. So in this chapter, we're going to identify the basic functions of the nervous system, and to identify also the different sections or divisions of the peripheral nervous system, the difference between sympathetic and parasympathetic divisions of the ANS, and compare the drugs that are going to be classified as cholinergic versus anticholinergic drugs. And we will give examples on that as well. So this slide provides the basic functions of the nervous and sections of the nervous system. So the nervous systems consist of two main subsystems. The first one is the CNS, which is the central nervous system, which comprise of two main components. The first one is the brain, and the spinal cord. That's for and that is identified or listed under the CNS. Now, under the PNS, which is the peripheral nervous system, we have two main systems: motor neurons and sensory neurons. The motor neurons are divided into either somatic or autonomic nervous system. So the focus of this lecture will be in chapter 12, will be on the ANS, the autonomic nervous system, which is consists of the sympathetic, two different fibers or nerve fibers and sections. The first one is sympathetic, and the other one is the parasympathetic. So the sympathetic, which is the adrenergic receptors, and the parasympathetic, which is the cholinergic receptors, in which chapter 12 focuses on the cholinergic receptors. However, the chapter 13 presents all and provides explanation about the adrenergic receptors, alpha and beta, alpha 1 and beta, alpha 2, beta 1, beta 2. So recap is that the nervous system consists of the CNS and the PNS, peripheral nervous system, central nervous system, brain and spinal cord, and the peripheral nervous system, motor and sensory. The motor that consists of the somatic and autonomic nervous system. So our focus will be on the ANS, autonomic nervous system, sympathetic and parasympathetic. Sympathetic, which is adrenergic alpha and beta receptors, and parasympathetic, which is the cholinergic receptors, which is the focus of this chapter 12. Here we also provide more explanation about that slide or the structure of the nervous system. The upcoming or the subsequent slides provides more explanation about the structure and the pathology and the pathophysiology or pathology of the nervous system. So the two major divisions we said are the CNS and the PNS. Now the peripheral nervous system, somatic and sensory, and then the autonomic nervous system, so the somatic, which is, when we say somatic nervous system, which is the voluntary control over skeletal muscles. So all the skeletal muscles are going to be controlled according to the somatic nervous system, which is a voluntary control. Now the ANS, which is autonomic nervous system, that's these are the muscles. Most of that will be like smooth muscles, and the cardiac muscle and the glands. They are controlled involuntary. So under the ANS, autonomic nervous system, sympathetic or parasympathetic, it includes all the involuntary control over the smooth muscles, the cardiac muscles, and the glands as well. So the neurons regulate the other cells, because there are two basic steps in the process by which the neurons will result in or elicit the responses from other cells. There is an axon, which is axonal conduction. So that conduction of the nerve impulse will go through the axon, so the axonal conduction, and then the synaptic transmission. I will provide more explanation about the post or the synaptic transmission and different types of transmitters, neurotransmitters like the norepinephrine, for example. Will provide the life cycle of the norepinephrine. Next slide explains also or provides more explanation about the sympathetic and parasympathetic. So before I go into the specifics about the functions of each system, that the ANS, the autonomic nervous system, it has three principal functions. The autonomic nervous system has three principal functions. The first one is to regulate the heart. Second function is to regulate secretory glands like the salivary glands, the gastric glands, sweat glands, bronchial glands, in which the secretions in the bronchial tree or the bronchial structure of the lungs. And the third function of or principal function of the ANS is to regulate smooth muscles like the bronchi and smooth muscle of the blood vessels, make it dilate or constrict. Urogenital system, GI tract, the smooth muscles in the GI tract, which causes the peristalsis. So the three main functions of the ANS: regulate the heart, regulate the secretory glands, and regulate smooth muscles. So the sympathetic nervous system, the SNS, it activates under stress, fight or flight response. It makes the body to be ready for an immediate response to a potential threat. So we go down to the three main functions of the sympathetic nervous system. So the previous were three main functions of the autonomic nervous system, sympathetic and parasympathetic. But now these three main functions are for the sympathetic nervous system, specific to the sympathetic nervous system, fight or flight response. First, response for regulation of the cardiovascular system. It will maintain blood flow to the brain, redistribution of blood flow during exercise, like when there is a vasoconstriction to increase cardiac output, compensation for loss of blood, primarily by causing vasoconstriction. So the first one is regulation of cardiovascular system, either by maintaining blood flow to the brain, reconstricting blood flow, redistribution of blood flow, or compensation for less of blood, primarily by causing the vasoconstriction. So the second is regulation of body temperature. So the first one we said is regulation of cardiovascular system. Second is regulation of body temperature. So it regulates blood flow to the skin. It promotes secretion of sweat or perspiration through the sweat glands. So these two main things or functions, they belong to the main one, which is regulation of body temperature. The third main function of the sympathetic nervous system, other than the regulation of cardiovascular system or regulation of body temperature, but also the implementation of fight or flight reaction. And we mentioned this earlier about the fight or flight reaction. Given that the sympathetic nervous system is activated under stress, like the increase, for example, increase in heart rate and blood pressure during the stress, fight or flight reaction. Second is that there will be shunting of blood away from the skin and viscera organs to the muscle, a dilatation of the bronchi, dilatation of the pupils of the eye, mobilizing stored energy like glucose for brain and fatty acids for muscles. So these are the three main functions of the sympathetic nervous system: regulation of cardiovascular system by maintaining blood flow to the brain, redistribution of blood flow during exercise, which will increase vasoconstriction, compensation for loss of blood, primarily by causing that vasoconstriction. And the second one is the regulation of body temperature by regulating the blood flow to the skin, promoting secretions of sweat glands. And the third one is implementation of fight or flight reaction by increasing heart rate, blood pressure, shunting blood away from the skin and visceral organs to the muscles, dilating the bronchi and dilating the pupils, and mobilizing the stored energy, like glucose for brain, fatty acids for muscles. And now the second part of the ANS, which is the parasympathetic nervous system. And it's usually activated under non-stressful conditions. Rest and digest response. The digestive processes promoted, heart rate and blood pressure decline due to this parasympathetic nervous system activation. So 7 functions are controlled under that parasympathetic nervous system. So it has 7 regulatory functions. So it regulates 7 functions. The first one is slowing the heart rate. So the activation of this parasympathetic nervous system results in slowing the heart rate, pulse, increase gastric secretions, emptying the bladder. So it's opposite to the urinary retention. So this is emptying the bladder. Second, emptying the bowel. So in sequence, we'll go from the first one, slowing the heart rate, increasing gastric secretions, emptying the bladder, emptying the bowel, focusing the eye for near vision, which is due to the constriction of the pupils of the eye, contracting bronchial smooth muscle. So the bronchial smooth muscle will contract, which results in bronchoconstriction. So these are the functions of, or the main 7 functions of the parasympathetic nervous system. So if we look at the cardiac in the middle of the slide, the activation of the parasympathetic nerve will result in slow heart rate, bradycardia. But if you activate the sympathetic nerve, that will result in accelerating and increasing the heart rate, tachycardia. So the balance between them that will, will maintain the heart rate within range. So these are the opposing effects of parasympathetic and sympathetic nerves. And that applies to all other functions as listed here on the right-hand side of the slide, or the right half of the slide, in which that you will see the activation of the parasympathetic division versus on the right side, which is the sympathetic division activation. So these are resultant physiologic changes from the parasympathetic nervous division activation, like parasympathetic result in constricted pupils, myoses. It stimulates saliva or salivation. It will slow the heart rate and contractility of the heart. It will constrict the bronchioles, bronchoconstriction, stimulate digestion, stimulate gallbladder function. It will result in contracting the bladder and emptying the blood, and urinary retention. It will also stimulate the erection and vaginal lubrication. The other side, which is sympathetic nervous system, we will find that the activation of the sympathetic division or nerve will dilate the pupils. It will inhibit saliva secretions, will accelerate the heart rate, will result in tachycardia and increased contractility, dilate the bronchioles, which is bronchodilation, inhibit digestion, stimulate release of glucose, hyperglycemia. It will secrete, the adrenal glands will secrete epinephrine and norepinephrine, which is the catecholamines. We call the epinephrine and norepinephrine catecholamines, which will result in peripheral vasoconstriction. These are vasoconstrictors. And also it will relax the bladder and to result in urinary flow. So it will, emptying the bladder and stimulate ejaculation and orgasm. So these are the functions of both sympathetic activation and parasympathetic activation. So the key towards understanding the content for this chapter is to identify and try to, and also define and able to memorize these functions. What would happen when the parasympathetic nervous system is activated, or the division of parasympathetic division is activated, or nerve is activated? That's what happened. Pupil constriction, saliva increased or secreted, bradycardia, bronchoconstriction, increased or stimulated digestion, stimulated gallbladder function, and contraction of the bladder. So these are some, some things that we would like to be able to recall, memorize, and that's the key towards understanding, the content, the subsequent content, and the complex mechanisms pertains to this and other chapters in pharmacology. And same things that, when you master the parasympathetic, you can predict the sympathetic, because for the most part, it's exactly the opposite to the parasympathetic. So if the parasympathetic activation will result in pupil constriction, myoses, then the sympathetic division activation or nerve activation of the sympathetic nervous system will result in pupil dilatation, which is mydriasis. So mydriasis, pupil dilatation due to sympathetic activation. Myoses, it's the pupil constriction due to parasympathetic nerve activation. So this is an example of how you're going to, maybe if you master one, side like parasympathetic, you can easily predict the sympathetic activation, because that's exactly the opposite. So the branches do not always produce the opposite effect. We said it's dichotomy in terms of sympathetic is exactly the opposite to the parasympathetic. I said to them for the most part, because the branches do not always produce opposite effects. For example, the sweat glands only controlled by these sympathetic nerves, the sweat glands. So next slide here, it's about the multiple drug receptors and selective drug action. So here in figure A, or if you look at the more and more all of Mort's organs are regulated through activation of type A receptors. All of them, all the organs in more, it's regulated by the alpha receptors, all the same receptor. So, which means that the drugs that affect type A receptors on one organ will also affect the type A receptors on all other organs. So hence we can say that the selective drug action is impossible here because we have all the organs are regulated by one receptor or have only one receptor. In Merv, that's who has 4 types of receptors, A, B, C, and D, to regulate his 4 organs. So the drug, a drug that acts at one type of receptor would not affect the other organs because they have different receptors. So hence we can say that selective drug action is possible in this case. So on the right side of the slide, we have the steps in synaptic transmission. So this applies to all different types of neurotransmitters. If that's a dopamine or norepinephrine or any type of neurotransmitter, that's usually can be like a foundation or a theory to be applied to all different types of neurotransmitters. So and which T will denotes the transmitter, which is a neurotransmitter T. So in step 1 there will be synthesis production of this neurotransmitter, which is T, from the precursor molecule Q, R, and S. Now in step 2, after the synthesis, the neurotransmitter usually will be stored. So there will be storage of the transmitter in some type of vesicles. That's in 2. So 1, synthesis from different types of precursors, and then 2 is the storage of this neurotransmitter, and then 3 will be the release of the neurotransmitter. So in response to an action potential, the vesicles will fuse with the terminal membrane and will discharge these contents into the synaptic gap right here. And then step 4, that's the action at receptor, in which that the transmitter will bind reversibly to its receptor, lock and key, we said, lock and key receptor, transmitter receptor interaction. So the transmitter will bind to this receptor, its receptor, on the postsynaptic, this one is postsynaptic cell. So this is presynaptic nerve ending, and this is postsynaptic cell. Can be a muscle, can be a gland, can be any cell. So that's binding number 4, action at receptor and binding. And then number 5 will be termination. It doesn't, it has a life cycle. In other words, that there is an end for this transmitter to an end point for this transmitter. So step 5 will be the termination of transmission, in which that the transmitter will dissociate from its receptor and then removed from the synaptic gap. And there are different ways or methods of this movement, but at least that will be the end of it in terms of that the neurotransmitter termination, and the end, that will be the life cycle for the transmitter from the synthesis down to the termination. Sometimes the transmitter will be like there's a reuptake into the nerve terminals. Sometimes it's the enzymatic degradation, like here, or diffusion away from the gap, completely is gone from the gap. So that's life cycle for any neurotransmitters or transmitters like norepinephrine, dopamine, and other transmitters. So the connection of 2 neuron outside the CNS, which is a ganglionic synapse, we have a preganglionic neuron and postganglionic neuron. So many drugs affect autonomic function by changing and altering the neurotransmitter activity at the second synapse, which is on the second half, which is postsynaptic neuron and its connection with the target tissue. So that's where then transmitter will have the most effect on the function. The drugs not intended to correct ANS, there are drugs used to stimulate or inhibit target organs of the ANS. Now, the primary neurotransmitters of ANS, we have acetylcholine and norepinephrine. These are the two main neurotransmitters in the autonomic nervous system. It's either the synaptic clef is either regulated by acetylcholine or norepinephrine, either at the ganglia or postganglia. Here we have the slight difference between the parasympathetic and sympathetic and somatic motor system. Motor system has the motor neuron that is, which will regulate the skeletal muscle. So our focus in this lecture is on the parasympathetic and sympathetic. The parasympathetic, we have a spinal cord, preganglionic neuron, ganglion, and postganglion. And then the various organs here controlled by this sympathetic nervous system and its neurons. Sympathetic, we have two different ones. The first one, which is the preganglion and postganglion, that's the any organ and sympathetic nerve other than the adrenal gland. So everything except the adrenal gland, because the adrenal gland, usually there is no continuous, there's no postsynaptic neuron, because the adrenal gland will release its hormones or its substances and chemicals and intrinsic hormones in the bloodstream, and it will find its own target organs. So the next slide also provides another more detailed information about the difference between parasympathetic and sympathetic. So under the parasympathetic, we have only acetylcholine that will control both pre-synaptic, the ganglion and postganglion. So preganglionic neuron with postganglionic neuron, there is a cleft, so that is controlled by acetylcholine. Same thing as the postganglionic neuron and the target organ also by acetylcholine. So parasympathetic completely is controlled by the acetylcholine neurotransmitter or transmitter. Now the sympathetic nervous system is controlled by both acetylcholine and norepinephrine. Acetylcholine mainly in the ganglion, and postganglion it's either norepi or acetylcholine. Sweat glands completely by acetylcholine, and the adrenal glands by acetylcholine and the epinephrine. More explanation here about the specific receptors at the ganglion and postganglion. The parasympathetic, so first of all, we have these cells are either nicotinic N receptors or muscarinic receptor. M indicates the or denotes the muscarinic receptors, and nicotinic N receptors, and the nicotinic muscarinic receptors, nicotinic M receptors. Right. A or B, that's an alpha, or B or just beta receptors. M again, muscarinic receptors. So in parasympathetic, it's controlled by, because we have various organs are controlled by this acetylcholine. So it's the ganglion, we have N nicotinic N receptors, and then at the target organ or various organs, we have the N receptors, M receptors, M muscarinic receptors. So, but both controlled by ganglionic or postganglionic, both by acetylcholine. Sympathetic, again, it's either acetylcholine or norepinephrine or epinephrine. So acetylcholine, epi or norepi, because the epinephrine is it's only will be secreted by the adrenal glands under the sympathetic. Sympathetic, again, it's acetylcholine or norepinephrine, in addition to the adrenal glands, which will secrete the epinephrine. So next slide provide an explanation of the life cycle. So before we go to the life cycle of acetylcholine and the dopamine, we have the different types of receptors: cholinergic, anticholinergic. Now, the subtypes of cholinergic and adrenergic receptors, when we say cholinergic receptors, I'm sorry, maybe this slide is much better to provide explanation about the difference between cholinergic receptors and adrenergic receptors. Now, cholinergic receptors, the nicotinic N receptors, nicotinic M receptors, M, which is muscarinic receptors, they belong to what is called cholinergic receptors. So these are subtypes of cholinergic receptors. So they control cholinergic, or they are at least defined as cholinergic receptors: nicotinic N, nicotinic M, and the M, which is muscarinic receptors. Now, the alpha 1, alpha 2, and beta 1, beta 2, and you can tell that it's both, they are under sympathetic. We don't have anything under alpha or beta under parasympathetic. So the alpha and beta, they are under sympathetic nervous system. So alpha 1 or alpha 2, beta 1, and beta 2. So these subtypes of alpha or beta, others 1 or 2, they are called adrenergic receptors. Adrenergic receptors. So that when we say cholinergic receptors, they control the, or they, listed as the N, nicotinic M, nicotinic M, nicotinic N and M, and then muscarinic, adrenergic alpha and beta. And also we have the third one, which is under the sympathetic nervous system, which is the dopamine. Dopamine, which is adrenergic, but responds to dopamine, not the norepinephrine. So we have also dopamine under adrenergic receptors. So if we compare between the three main transmitters, the acetylcholine, norepinephrine, and epinephrine, the acetylcholine, it's employed at most functions of the peripheral nervous system, acetylcholine. Norepinephrine, released by most postganglionic neurons, except for the sweat glands. That's for the sympathetic nervous system. And then for the epinephrine, the epi is released, as you see here, by the adrenal medulla or adrenal gland. So the epinephrine will activate, so that if the epinephrine can activate the alpha and beta receptors, the norepi, can control alpha 1, alpha 2, and beta 1 receptors. Dopamine can activate alpha 1, beta 1, and dopamine. So the epinephrine is the only transmitter that acts at beta 2 receptor, epinephrine. When we say during the fight or flight response, there will be dilatation of blood vessels in the heart and lungs and skin and muscles, which will increase perfusion from this dilatation of blood vessels, dilatation of the bronchi or bronchial tree, which will increase oxygenation, increase glycogenolysis, which will result in increased blood sugar, which is the conversion of glycogen in the liver into glucose, and also relaxing the uterine smooth muscle. So this slide provides the life cycle of both the acetylcholine and the dopamine. So as we review the life cycle from the synthesis of acetylcholine to the release of the acetylcholine to the cliff, and then binds to the N or nicotinic or M muscarinic receptors, the activation will result in the muscle contraction. So that's how the neuromuscular activity occurs. And the muscle contraction will result from the acetylcholine activation to the unbinding of this SEH or SEH transmitter to its receptors. So that activation will result in the muscle contraction. So the acetylcholine will be degraded into choline and acetate. That's the degradation of the acetylcholine by an enzyme called acetylcholine cholinesterase enzyme. So acetylcholinesterase enzyme, ACHE, this enzyme is responsible for the degradation of the acetylcholine. So it will deactivate the acetylcholine. So that at least, but this is the life cycle of the acetylcholine. So we can apply the same principle of the synthesis, release, binding or activation, and then degradation or termination. That's the life cycle for the norepinephrine. But so acetylcholine activates the nicotinic or M receptors. However, the norepinephrine will activate the cholinergic receptors, which is the alpha or beta receptors. Sorry, adrenergic receptors, alpha or beta. So the acetylcholine and cholinergic transmission. There are, we said, two types of cholinergic receptors: nicotinic receptors and muscarinic receptors. So nicotinic receptors because this the nicotine binds to these receptors, and also muscarinic receptors named because the mescaline from poisonous mushrooms bind to these receptors. That's the origin of naming these receptors, so nicotinic or muscarinic receptors. So the nicotinic receptors, they are located at the ganglionic synapse in both sympathetic and parasympathetic divisions. And the response is to stimulate smooth muscle, stimulate gland secretion. Muscarinic receptors, they are located at the parasympathetic target organs except the heart. So if we go back here to nicotinic receptors versus muscarinic receptors, nicotinic, disregard what what I just said about it's not that important. The origin of the naming of the N versus M nicotinic, because it's binds to the nicotine binds to these receptors, and the M, why the M receptors called muscarinic receptors. However, the most important thing about the N versus M receptors, that the nicotinic receptors, they are located from this slide at ganglionic synapse in both sympathetic and parasympathetic divisions. The response to nicotinic receptors, stimulation of smooth muscle, stimulation of the gland secretions. So we'll expect more secretions from the activation of the nicotinic receptors. Stimulation of smooth muscle. The M or muscarinic receptors, and they are located at the parasympathetic target organs except the heart, the M receptors. And they will also stimulate smooth muscles and secretion. But I will provide more explanation about the difference between these two in terms of the stimulation of a smooth muscle and gland secretion in either one. So the classification and naming of autonomic drugs. When we say cholinergic drug or anticholinergic drug, what's the source of this naming? Or how we came at to that specific name of saying this is cholinergic or versus anticholinergic. So based on two possible actions in which that sympathetic versus parasympathetic, the stimulation of the parasympathetic nervous system, these medications are called cholinergic drugs or agents. It's exactly the same as parasympathomimetics. So parasympathomimetics, it's got quite long name and term, but usually it's exactly the same as when you as the cholinergic. When it's the cholinergic agent or drug, it's the same as parasympathomimitic agent. And same thing now with the parasympathetic nervous system, the inhibition of the parasympathetic. So when you activate the drug that will activate the parasympathetic nervous system, the activation, this drug, if it activates the sympathetic nervous system like an agonist, it will result in, it's called cholinergic drug. If this drug inhibits the parasympathetic nervous system, then it's an antagonist to the parasympathetic nervous system. It's inhibit, antagonize, block it. So that's the cholinergic blocking agent. In other words, it's anticholinergic drug or parasympathetolytic. So we will, I prefer using the short, an easy term, which is cholinergic versus anticholinergic drugs. So the activation, the agonist or the activation of the parasympathetic is called cholinergic drug. The antagonist inhibitor for the parasympathetic is called anticholinergic drug. So now we know that cholinergic versus anticholinergic drug under the parasympathetic nervous system medications. So the cholinergic drugs, they are either direct acting or indirect acting. They are considered or classified as a direct acting cholinergic drug if they bind to the cholinergic receptors to produce the rest and digest response. I will have more explanation about, in the upcoming slides. But the indirect acting, so the indirect acting, it will inhibit the action of acetylcholine esterase enzyme. Remember that acetylcholine esterase or cholinesterase enzyme, this enzyme responsible for the degradation of the acetylcholine. So this indirect acting, it's the inhibition of the action of this enzyme, cholinesterase enzyme. Or acetylcholinesterase enzyme, ACHE, acetylcholinesterase enzyme. So, and this indirect acting, in which there will be inhibition of the action of the acetylcholinesterase enzyme, it has a high potential for serious side effects. So the cholinergic agents or medications, the first type drug for this one is that bethanychol, choline, and the mechanism of action is to activate the parasympathetic nervous system directly or indirectly to induce the rest digest response. So it's a non-obstructive, the therapeutic classification will be a non-obstructive urinary retention drug. So it's very effective in non-obstructive urinary retention. Pharmacologic class would be muscarinic, which is M from M receptors, muscarinic cholinergic receptor drug. So this drug is a direct acting parasympathetic mimetic drug that interacts with the M receptors, muscarinic receptors, to cause actions typical of the parasympathetic stimulation. If you're, so at this point, if you review go back to the parasympathetic nervous system stimulation, this drug is going to result in the same functions or effects of stimulating the parasympathetic division. So its effects are most noted or apparent in the digestive and urinary tract. So in the GI and urinary tract, where it stimulates smooth muscle contraction. So these actions are useful in increasing smooth muscle tone and muscular contractions in the GI tract following general anesthesia, for example. In addition, it is also used to treat non-obstructive urinary retention in patients with like a lack of muscle tone. It's called atony of the bladder. This drug never administers as an IV or IM. It's an oral, and sub-Q doses are not interchangeable. So we have to monitor the blood pressure, pulse, respirations before administering the drug for at least 1 hour after sub-Q administration. The adverse effects. Contraindications, patients with asthma, epilepsy, Parkinsonism, hyperthyroidism, safety also in pregnancy and lactation in children younger than 8 years is not established. But we have to be careful with the that these are the specific contraindications for this drug, like patients with asthma, epilepsy, Parkinsonism, and hyperthyroid. The drug-drug interactions, with botanical, it will include the cholinergic effects from cholinesterase inhibitors and decreased cholinergic effects from medications like procainamide, which is a cardiac medication, quinidine, another cardiac med. Procainamide, Procainamide, quinidine, atropine, epinephrine. So these are the drug-drug interactions. So which includes the drugs that has an increased cholinergic effects and decreased cholinergic effects, such as procainamide, quinidine, atropine, and epinephrine. So atropine is an anticholinergic effect, so it will decrease cholinergic effect in this case. So there will be a drug-drug interaction with atropine, as an example. Now, the treatment of overdose, atropine sulfate is a specific antidote. If patient happens that the patient would develop toxicity to botanical, then as a cholinergic drug, then the anticholinergic drug, which is atropine, can be used as a antidote for botanical overdose. Sub-Q injections of atropine is preferred, except if that's an emergency, and that's what the IV route that may be kind of used in the emergency setting. So a list of medications similar to botanical as a prototype drug. Pilocarpine. So we have two classifications or sub-classifications: direct acting and indirect acting. Direct acting on the receptor. Botanical, pilocarpine, botanical for urinary retention, pilocarpine for glaucoma, which is an eye drop. The cholinesterase inhibitors, ACHE enzyme inhibitors, that's the indirect acting. So most of these meds are Alzheimer's disease medications. So many meds for the Alzheimer's disease, or myasthenic gravis, or can be used also post-op urinary retention from anesthesia. Patient can develop a urinary retention due to anesthesia. So these are also medications that can be used. Donepezil, donepezil, Aricept, Rezidine, prostigmine, and then we have the physostigmine, which is the another prototype for the indirect subclass. So we have direct acting prototype drug is botanical, and the physostigmine is the prototype for the indirect type or indirect classification. So the physostigmine, which is very effective drug for myasthenia gravis, very effective in patients with MG, myasthenia gravis. And it can also be used to treat patients with the anticholinergic toxicity. Patients, for example, who would consume or take large doses or too many doses of atropine as an anticholinergic, for this toxicity to atropine, the physostigmine would be the antidote for that. So the physostigmine, which is the antidote for anticholinergic toxicity, it's the acetylcholinesterase inhibitor, so it inhibits the enzymes that degrades the acetylcholine. Actions and uses the stigmine is an indirect acting parasympathetomimetic um, that inhibits the destruction of the acetylcholine by acetylcholinesterase enzyme. So its effect occurs at the neuromuscular junction and central and peripheral locations where the acetylcholine is the neurotransmitter. So it reverses toxic and life-threatening delirium caused by atropine. So it's the antidote for atropine toxicity. And this is a very important concept. Physostigmine is the perfect drug antidote for atropine overdose or atropine toxicity. Or delirium, life-threatening delirium caused by not just the atropine, diphenylhydramine, diphenhydrate, and other, but this is the most important, which is atropine toxicity or diphenylhydramine. And it's administered as an injectable solution, IM, IV. So it administers slowly over 5 minutes to avoid seizure and respiratory distress. We should not use continuous infusions. Should not be, never be used, continuous infusions of this drug. And we monitor the blood pressure, pulse, respirations, and the adverse effects. Bradycardia, asystole, life-threatening dysrhythmia, restlessness, nervousness, and seizures. Myasthenia gravis, which is the neuromuscular disease characterized by fluctuating muscle weakness and predisposition to rapid fatigue. So a patient will be extremely exhausted and fatigued from minimal activity, and common symptoms will be like ptosis, dropping of the eyelid, dysphagia, difficult swallowing, weakness of the skeletal muscle. So easily fatigued, can get tired, get very tired and fatigued from minimal activity. So it's an autoimmune process or disease in which the antibodies will attack the nicotinic M receptors on the skeletal muscle. So the patient, when they develop the myasthenic crises, in which that there will be inadequate treatment with the cholinesterase inhibitor, esterase inhibitors, that will result in muscle weakness. So patient on taking the medications for the myasthenia gravis, when they receive inadequate treatment with these, the medications to treat myasthenia gravis, the MG, is called cholinesterase enzyme inhibitors. The drugs that will inhibit the activity of the enzyme, which is responsible for the degradation of the acetylcholine. So when the patient receives insufficient amount of this drug, will result in muscle weakness. So because the decrease in acetylcholine will result in at the neuromuscular junction, it will result in, and especially if left untreated, that could be life-threatening and result in paralysis of the respiratory muscles and lead to death. So respiratory muscles and death could result from the inadequate treatment of the MG, especially when left untreated for a while. The treatment for that will be the stigmine, or physostigmine. So the most important thing about the physostigmine as a drug or medication to treat, which is the classification of the drug is cholinesterase inhibitor, cholinesterase enzyme inhibitor. The drugs or the medications should be scheduled according to the patient's activities. So it should be prescribed and timed the drug administration with anticipation of exhaustion or activity, or patient is going to have a short walk or conversation over the phone or going to the outside to the mall. For any activity, we have to time the effect of the drug with the anticipation of patient's activity. So beneficial effects: increased muscle strength. So physostigmine will increase muscle strength. And we have always make sure that patient is able to swallow, because the swallowing can be adversely affected by the disease, by the MG, by myasthenia gravis. So make sure that patient is able to swallow, otherwise they will aspirate. Side effects will like excessive muscarinic receptors response. So we treat that with atropine. The dosage adjustment. So we have to start small at small dosage and adjust to patient response. We need to modify the dosage in anticipation of exertion. In anticipation of exertion, like eating, shopping, talking, on the phone, ambulation, any activity, or anticipated exertion. So we have to modify the dosage and the timing that the administration of the dose in anticipation of exertion or any activity. Signs of under medication: ptosis and difficult swallowing. Signs of over medication: excessive saliva, so physostigmine, that's the drug we be discussing a few minutes, and it's contraindicated, or at least can be given, but with caution, in patients with asthma, epilepsy, diabetes, cardiovascular disease, bradycardia. So you will discontinue the drug if excessive sweating, diarrhea, frequent urination occurs, because that's a sign of overdose. Excessive saliva, diarrhea, frequent urination. Drug-drug interaction. The level of physostigmine may be increased if it's given, if it's administered with the corticosteroid, systemic corticosteroid. So the level of the physostigmine may be increased by systemic corticosteroid. Labs that may increase the ALT, AST, and amylase, and the overdose. The atropine always should be available, because the atropine is the antidote for physostigmine overdose. Cholinergic blocking or inhibitors, or what is called anticholinergic drugs. The effects would include pupil dilatation. So these are the functions we included in the one of the first slides. The difference between sympathetic and parasympathetic. But here, The side effects will be pupil dilatation. So patients on cholinergic blocking agent, anticholinergic drug, they will have mydriasis, which is pupil dilatation, increased heart rate, tachycardia, drying glandular secretions, decreased secretions, drying of the gland secretions, and bronchial constriction. Bronchial dilatation, because that will result in relaxing the bronchi. Now, the use would include, so what are the indications to treat patients with this drug? The anticholinergic would be to treat the peptic ulcer disease, ophthalmic procedures, or can be used in ophthalmic procedure for pupil dilatation, heart rhythm abnormalities. So it will increase. So patients with like bradycardia, we can give them this anticholinergic to increase the heart rate, boost the heart rate to higher than 60, for example. Patients with asthma and COPD will benefit from this drug. Overactive bladder, Parkinson's disease. So the anticholinergic drugs, or cholinergic blocking agents or anticholinergics, atropine, penstropine, Vigentin, dicyclamine, Bentyl, and ipratropium atropine. And we have the primary use for each one on the right side column of the table. Other medications would be the oxybutynin, which is ditroban or oxytrol, propanthelin, scopolamine, it's a widely used drug, scopolamine, or transderm scope patch, Spirivia. Tiotropium Spiriva also is very, very effective drug for asthma and COPD. So the anticholinergic and scopolamine. Scopolamine is an anticholinergic drug which has actions very close to or much like those of atropine. With two exceptions. So if we say that the scopolamine or anticholinergic, and it's very similar to the atropine with two exceptions. The first one is that whereas therapeutic doses for atropine produce mild CNS excitation, therapeutic doses of scopolamine produce sedation. The second one is that the scopolamine suppresses emesis, which is tendency to vomit or the emesis. So the second exception is that the scopolamine suppresses emesis and motion sickness, whereas the atropine doesn't. So the principal use for the scopolamine as an anticholinergic are motion sickness and mydriasis during the ophthalmic procedures. If they want to do pupil dilatation during ophthalmic procedures, scopolamine will be great for that medication for this. And also can be used as to produce the pre-anesthetic sedation and obstetric amnesia during labor. So the most common drug used for motion sickness is the scopolamine, which is a transderm scope patch. So the role of the nurse and taking care of the patients or providing care to patients on cholinergic drugs affecting the ANS, monitor for the intake and output ratio, for the blurred vision, monitor for orthostatic hypotension. That's for direct acting. For the cholinesterase inhibitors, you monitor for the muscle strength and neuromuscular status. Ptosis, dropping of the eyelid, or diplopia, double vision, or chewing and swallowing ability. Schedule medications around the mealtime, and also schedule activities to avoid fatigue and exhaustion. And you monitor for muscle weakness. That's very important to monitor for muscle weakness. And the role of the nurse would be monitor for patient's condition, provide education on drug therapy. You will note the adverse effects of the drug therapy and identify any possible interactions or contraindications of drug therapy. So therapeutic class, antidote for anticholinergic poisoning. That's the cholinergic blocking agent, which is anticholinergics like atropine. So these medications, the anticholinergic drugs, the mechanism of action, it's that in which that the occupy mescarinic receptors, the M receptors. So like atropine, it will block the parasympathetic action of the acetylcholine and induce symptoms of the fight or flight response. So most prominent are increased heart rate. So when you give atropine, the heart rate will jump, so it will increase. It will result in bronchodilation, so that's why it's good. The anticholinergic drugs are good for not the atropine, but the other medications for asthma and COPD. Like one of the in that table, we highlighted one of the medications. The very last med in that table, on the second table, was ipratropium atrovent. Ipratropium atrovent. It's an anticholinergic, but it's very effective drug inhalation therapy for asthma and COPD. And the anticholinergics will decrease motility in the GI tract, decrease secretions from the glands, drying the drug. It will make the body dry because it will decrease the secretions from the many glands, especially the sweat glands and other glands. Mydriasis, like it will result in dilatation of the pupils as an anticholinergic drug, pupil dilatation, mydriasis. So at therapeutic doses, the atropine has no effect on nicotinic receptors in ganglia or on skeletal muscle. At therapeutic dose, the atropine has no effect on nicotinic receptors in ganglia or on skeletal muscle. So although the atropine has been used for centuries for a variety of purposes, its use has declined in recent decades because of the development of a safer and more effective medications. So we sometimes prescribe the atropine to treat hypermotility, diseases of the GI tract, such as the IBS, which is irritable bowel syndrome, to suppress secretions during surgical procedures, to increase the heart rate in patients with bradycardia, or dilate pupil or the pupils during the eye examination. once widely used to cause bronchodilation in patients with asthma, the atropine. Now, the ipratropium has still been a great inhalation therapy for asthma and COPD, but the atropine, once widely used to cause bronchodilation in patients with asthma, it's now rarely prescribed for this disorder. So atropine therapy is useful for the treatment of reflexive bradycardia in infants and infantile hypertrophic pyloric stenosis. Which this will, you'll learn about this in PEDS course. So the drug atropine, it will inhibit the parasympathetic nervous system. And primary use, we said, peptic ulcer disease, IBS, mydriasis, and cycloplasia during the exam. Cycloplasia, which is the paralysis of the ophthalmic muscles. So to result in complete dilatation. That's cycloplasia. So when you say mydriasis is connected to the cycloplasia and the eye during the eye examination, they dilate the eye with, because the effect on, of the atropine is as a cycloplegic medication that will result in paralysis of the ophthalmic muscles. Bradycardia, also another indication of primary use. Pre-anesthetic drug because it will result in decreased secretions, so it will be much easier for the surgeon to work on the organs with less secretions during surgery. So myasthenic crisis and cholinergic crises. Cholinergic crisis resulted from the overdose with cholinesterase enzyme inhibitors. And it's characterized by extreme muscle weakness, or paralysis, and signs of excessive muscarinic stimulation, M receptor stimulation. So the treatment for cholinergic crisis would be the respiratory support, like mechanical support, and atropine. So to distinguish between the myasthenic crisis and cholinergic crises, so cholinergic from receiving too much of that cholinesterase inhibitor medication, overdose with the cholinesterase inhibitors medication. So we have endotropium, entrophonium, tensilon, edrophonium or tensilon test. Tensilon or edrophonium is the ultra-short cholinesterase inhibitor enzyme. Its effect is very short, for a few seconds, less than a minute. So once we give the edrophonium or tensilon, can be just used for diagnostic purposes, just to differentiate between if that's a myasthenic crisis versus a cholinergic crisis, because the symptoms are very similar when it comes to myasthenic and cholinergic crisis. So the edrophonium, if it alleviates the signs and symptoms and manifestations from the increased acetylcholine, then that is the myasthenic crisis. Given the edrophonium and it intensifies the manifestations, signs, and symptoms, then it's a cholinergic crisis. So that's why it's always important that we should have the atropine and oxygen available prior to starting this edrophonium or tensilon test. And I will provide more explanation in class about the difference between cholinergic and myasthenic crisis. Atropine, adverse effects with atropine. So before we go to the adverse effects of atropine, let's just review some of the pharmacologic effects of atropine. That the drug can be given PO, IM, IV, or sub-Q. The atropine therapeutic uses, we can give the atropine pre-anesthesia, as in, pre-anesthetic medication for disorders of the eye, like during the eye exam, for bradycardia to increase the heart rate, patients with intestinal hypertonicity and hypermotility of the GI tract, like diverticulitis, for example, IBS, irritable bowel syndrome, muscarinic agonist poisoning, like organophosphorus poisoning. Atropine will be a great medication and very effective medication to treat the muscarinic agonist poisoning, like organophosphorus poisoning. So the side effect of atropine limit its therapeutic usefulness and are predictable extensions of its autonomic actions. Extended side effects would include dry mouth, constipation, urinary retention, increased heart rate, and the initial CNS excitement or stimulation. It may progress to delirium and even coma. So the atropine is contraindicated in patients with glaucoma because the drug may increase pressure within the eye. So the intraocular pressure may elevate or increase in response to the atropine and its effect on the eye. So it's contraindicated in patients with glaucoma. And also, atropine should not be administered to patients with obstructive disorders of the GI tract. The obstructive disorders of the GI tract, patients with parotid ileus, bladder neck obstruction, patients with prostate hyperplasia, BPH, benign prostate hyperplasia. That's a contraindication for the use of atropine. Myasthenia gravis is contraindication, another contraindication. Acute hemorrhage, another contraindication. Treatment of overdose, so a short-acting barbiturate or diazepam may be administered to control convulsions. But the antidote for the atropine poisoning, so patients who had developed atropine poisoning, the overdose for that can be treated or should be treated with physostigmine. So physostigmine, the drug we mentioned or discussed earlier, that's the antidote, which is a cholinergic drug, should be used as an antidote for atropine poisoning, which will quickly reverse the coma caused by large doses of atropine. And this concludes the lecture for chapter 12.